So when you, in terms of communicating with patients about how long a drug will be effective, primarily, I guess it's very difficult sometimes to actually talk about numbers in this setting. Patients will have already gone through a considerable amount of their journey, and so it'll be very much an individualised approach in terms of trying to predict the further survival. I think you have to be realistic and indicate that the control is likely to be relatively short, so you would define that in months, but that may be some to many. But it is important to make that definition. And then, of course, some of these patients, or a lot of these patients, are still quite well at the end, and then we would look at other treatment options beyond that, often again clinical trials. The time to start talking about treatment options for refractory disease, I guess that will again depend on the clinician often, and also the patient. So patients, for example, will start to discuss what my options are, particularly after they may have had their first treatment and have then acknowledged that their disease is going to require different treatments. They'll start to talk about what the options are in the future. But for others, it'll really be a continuum. So what's next? And they may not really want to look beyond that. So it's individualised. So when we're considering clinical trials, there are a number of considerations we need to think of. Firstly, whether there are trials that are specific for their disease. So trials that patients with colorectal cancer can progress into, where the drug we know has some activity in colorectal cancer. In this setting, in the refractory group, the trials are often what we call phase 1 studies, where we're essentially investigating new agents where we don't really understand what the activity will be in colorectal cancer. And it's a very different type of study and requires a careful discussion around the benefits of an investigational drug and potential side effects versus perhaps focusing more on symptom control. So when we're looking to help patients decide, I think the crucial thing is trying to communicate all of the pros and cons. So as I alluded to before, there are certain benefits to trials where new drugs are available. So we know there is activity in colorectal cancer, so you need to communicate what that activity would be, but also bearing in mind that it may not work. So, and you need to balance that for these patients because they are becoming more symptomatic. So they do have more risks of side effects. So there is then a change in the way you discuss aggressive therapy versus maybe more focusing on quality of life and time. So it's a matter of communication, careful communication about those pros and cons. So why is AGITG or the Institute's work important? Well, in the setting of refractory colorectal cancer, of course, I mean, the group looks to seek out clinical trials that are relevant and accessible to patients in that group. I mean, overall for colorectal cancer or GI cancer, obviously, it does relate to clinical trials, access to new drugs, and then, of course, the Institute talks to patient information, advocacy to a degree to hopefully translate the trial outcomes into actual drug access for patients and improvement in patient outcomes and what follows from that. So it's primarily focusing on clinical trials, but it's then the access and the improvements in patient care which I guess follows.